Yeah, you are right, Swasti. And Salam Bombay Foundation is in a very kind of unenviable position to do that. It has been organizer of all the national conferences on tobacco or health and the World Conference on Tobacco or Health, and it has a firm footing as an NGO in Mumbai, and is continuously working on tobacco control, and that's the main focus. So I think SBF is very well placed to do what you have just suggested.
So we'll keep that in mind. So sure.
Yeah, I think all the panelists have joined, and a significant number of participants have also joined. So let us start the webinar. So let me start by welcoming all. Good afternoon to all. Yes, sir. Yeah. So let's start. Good afternoon to all the participants, panelists, and team members. Myself, Dr. Abhiram from Salam Bombay Foundation. Have joined, and a significant number of participants have also joined. So let us start the webinar.
Sorry, there is some echo.
So let me start by welcoming all. Good afternoon to all. Yes, sir. Yeah. Am I audible? Hello?
Yes, you are audible.
Yeah. Over to you, Dr. Dinesh.
Yeah. And myself, Dr. Dinesh from Narottam Seksaria Foundation. We would like to extend our warm welcome to all of you. We are glad that we have received this kind of participation. You just mentioned that there were about 600 registrations so far. So it is really heartening that you all have taken time out on this Saturday afternoon to come here for this webinar on tobacco cessation. And also hoping many more will also be witnessing this discussion live on our YouTube channel. So with your kind attention and consent of our moderators and panelists, here we would like to formally inaugurate today's session with a virtual lamp lighting ceremony. I request IT support to kindly facilitate the same.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते.
Today, Salam Mumbai Foundation, Narottam Seksaria Foundation, and Project Life First, in observance of World No Tobacco Day 2021, have jointly organized this discussion. The title of the discussion, as all of you know, is Tobacco Cessation in India, Policies, Practices, and Challenges. As all of you must be aware that every year, World No Tobacco Day is observed on 31st May, and every year there is a specific theme. So the theme for World No Tobacco Day 2021 is Commit to Quit, which deservingly redirects the focus on tobacco cessation. Our today's discussion is planned to be a reflection on the current status of tobacco cessation policies in our country across the various levels of organizations, including the central government, the state government, and also at the workplace levels. And while doing so, we will also look at the most vulnerable population from policy point of view. Today's discussion is also envisaged to provide an overview of varied cessation policies, that is, its different models and implementation and associated challenges too. And it will also intend to touch upon various modalities of cessation interventions and its reach so far in our country. And the discussion will be conducted in a planned panel discussion in the form of question and answer session, wherein our moderators will be asking the questions to the panelists. So it is indeed our privilege to introduce the esteemed panel as well as our moderators for today's webinar. Let me start with the introduction of the panelists in today. Our first panelist in today's webinar is Dr. Swasti Charan. Dr. Swasti Charan is Additional Deputy Director General and Director EMR in Director General of Health Services at Union Ministry of Health and Family Welfare. And he's currently leading 3 national level non-communicable disease programs, including National Tobacco Control Program. He prioritizes public health issues based on the evidence and best practices from across the world and adapts them in Indian situation. Welcome, Dr. Swasticharan.
Next panelist we have is Dr. Prakash Gupta, as or PC Gupta, as he's fondly addressed. He's a director of Healy Sexare Institute for Public Health, Navi Mumbai. Being a visiting scientist at Harvard T.H. Chan School of Public Health, he is an adjunct professor of epidemiology and biostatistics at the Arnold School of Public Health, United States. Dr. Gupta has received several awards, including Luther Terry Award from the American Cancer Society in 2003 and Tobacco Free World Award from the Director General, World Health Organization. Dr. Gupta is a mentor figure to us all in tobacco fraternity. Please accept our warm welcome to this session, sir.
Thank you.
Next panel.
We are glad to have Dr. Pratima Murthy in today's panel. Dr. Murthy is professor of psychiatry and head of the department at National Institute of Mental Health and Neurosciences, which is popularly known as NIMHANS, Bangalore. She is leading Tobacco Quitline for Southern India region, and she has authored manuals for tobacco cessation for doctors, dentists, as well as health workers for WHO Southeast Asia Regional Office. And she has also developed standard treatment guidelines for substance use disorders for Ministry of Health India. And she was also one of the international consultants for WHO ITU Mobile Cessation Program for Tobacco. Welcome, Dr. Murthy, in today's webinar.
Thank you.
Our next panelist is Dr. Upendra Bojani. Dr. Bojani is director at the Institute of Public Health, Bengaluru. He is currently holding a DBT Wellcome Trust India Alliance Fellowship. He is also a fellow at the John Hopkins Global Tobacco Control Leadership and the Arthra Leadership Accelerator Program. His research work covers various areas, including chronic condition, tobacco control, health policy and systems, political economy of health, and health inequity. We'd like to welcome you, sir, for this session. Next panelist, please.
Next panelist in today's webinar is Dr. Vikrant Mohanty. Dr. Mohanty is currently Associate Professor and Head of the Department, Maulana Azad Institute of Dental Sciences. And he's also the Principal Program Coordinator at National Resource Center of Oral Health and Tobacco at Maulana Azad Institute, Delhi. He is a technical expert in national policy and resource material development process, and he has contributed and acted as technical expert in operational guidelines on establishing tobacco cessation centers in dental institute across the country. We would like to welcome Dr. Mohanty in today's webinar.
Thank you so much.
Yeah, next in our panel is Ms. Manisha Khanna. Ms. Manisha is Plant HR Manager at Ambuja Cements Limited, Magdala Unit, Surat. She has completed her master's in business administration in HRM and has 13 years of experience in human resource management. She is one of the members who actively led the tobacco-free workplace program at the ACL, that is Ambuja Cements Limited, Magdala Unit, and still continues to do so. We welcome you, ma'am, for this session.
Thank you so much.
As we have stated earlier, this session will be thankfully facilitated by our moderators in this session. And let us take the privilege to introduce our moderators in today's session. Dr. Monique Kamath will be moderating today's session. Dr. Kamath is Chief Executive Officer of Narottam Sexaria Foundation, and in her present role as Chief Executive Officer at Narottam Sexaria Foundation, she advocates for tobacco cessation and reducing tobacco-related illnesses, deaths, environmental degradation, and poverty across the world. And she has also been actively involved with Medicine Sans Frontiers governance for several years. We welcome Dr. Monique Kamath.
Thank you. Thank you.
Dr. Monique is joined by Dr. Rimanshu Gupta. Being a senior colleague, he is also General Manager at Narottam Sexaria Foundation. He leads the Life First Tobacco Cessation Program, has an experience of more than 20 years in public health, has keen interest in operational research, and has published several papers on operational issues in the field of tuberculosis and tobacco cessation in national and international journals. We welcome you, Dr. Rimanshu, to the session.
Thank you.
Okay, so now the stage is set. So before going ahead, I would like to inform all the dear participants in today's webinar. Please take a note that The question and answer box as well as chat window can be used to submit all your queries to the panelists. And we would like to cover as many queries as possible as the time permits. So now looking forward to an enriching discussion and requesting kind attention of all the participants. Now, from here on, I would request Dr. Monik and Dr. Himanshu to please take over from here. Thank you.
Thank you, Abhiram. Thank you for handing over to Dr. Himanshu and me for a very exciting evening, exciting afternoon and session. We look forward to hear from our esteemed panelists who are experts in tobacco cessation and the whole service delivery model.
Good afternoon, everyone. Today we are going to talk about tobacco cessation. So tobacco cessation has always been part of the Empower project of Empower package of the WHO. So this O in the Empower was the offering help to quit tobacco. So a few years back, this was also referred to as the Orphan O because nobody was looking up to it. There was not much importance given to tobacco cessation. But I'm happy to say that the situation has changed. And today we are talking about tobacco cessation at the global level, and it is also the theme of the World No Tobacco Day this year. Before we go into the interesting discussion that is going to follow, I would like to just give you a brief overview of the Life First program. So Life First is a tobacco dependence treatment program, which was initiated by the Narottam Seksare Foundation and in collaboration with the Salam Bombay Foundation in 2012. It is an evidence-based program, and we have based it on the models of the Mayo Clinic, the Ottawa model, the Massachusetts General Hospital model, and we've adapted it to the local Indian setting. We have three arms of the program. One is, of course, the cessation counseling service that we provide. Second is trainings, and third is research. The counseling service is provided by our trained counselors in different settings. These include healthcare settings like hospitals. Here we are talking about both government as well as private hospitals, and also it is provided either on an OPD basis and also in some cases on the IPD basis. We also work through primary healthcare settings, TB treatment centers, antenatal clinics. The non-healthcare settings include workplaces and schools, where we provide cessation for students using supari and tobacco through a structured program. We also work at the community level through various NGOs. Our training module for healthcare providers has been developed in collaboration with the Harvard T.H. Chan School of Public Health. And we have trained more than 4,000 healthcare providers so far. These include doctors, nurses, dentists, and other paramedical staff. We have also launched an online course a few months back on tobacco cessation, and it has received a very good response. Our research is based on interventions at these different settings, and it is aimed at creating evidence and establishing models for dissemination so that more such services can be initiated. Our research partners have been the Harvard T.H. Chan School of Public Health, the Dana-Farber Cancer Institute, Massachusetts General Hospital in Boston, Willis Seksare Institute, and the Institute of Public Health from Bangalore. We have recently also been awarded an NIH grant, and we look forward to implementing this grant. Overall, if we talk of the reach of the program, till date, we have about 18,000 tobacco users who have registered with Life First for counseling. And at the end of our 6-month intervention, the 7-day point prevalence abstinence has been around 53% among the registered users. There has, of course, been some variation across the different settings. So this was in brief about the program itself. Dr. Moni?
Sorry. Thank you, Dr. Himanshu. So let us begin our conversation with Dr. Swasthi. Good afternoon, Dr. Swasthi. Your name is well associated with the field of NCD, public health, and tobacco control. We're eager to hear about tobacco cessation under the NTCP. Could you please let us know your views on the national situation in terms of availability of the cessation centers through NTCP, sir?
Thank you, Mohanty. And first of all, I would like to thank Salam Mumbai Foundation for organizing this and inviting me as one of the panelists. It's very important. We have heard some of us already telling us the O component of the Empower, WHO Empower, which was, not as great before. But when we started working on this area, we found that we could do so many things in this O component, and rather, from from the orphan, we could change into something very, very important and very, very powerful. Under the National Tobacco Control Program, we already support tobacco cessation centers in the district hospital. So as to mean that, when the state government submits a proposal for support under National Tobacco Control Program, there is a provision for a tobacco cessation center, which is to be established at the district level. Usually it's in the district hospital. So the first, kind of a brick and mortar tobacco cessation center is there in all the districts, and the proposal can come from any of the districts, and because of certain issues within the district, certain issues in not getting the whole of the support, and rationalization of the manpower to actually see in the field, we have about 500 of them as of now in the districts. These challenges arises because under the National Health Mission, we are also trying to rationalize the manpower. If you have a counselor for mental health, if you have a counselor for, the NCD program, there is no point, the two of them sitting together and counseling separately. So one patient who is an NCD patient may be a tobacco user. So I stopped counseling at, for NCDs at one point, and on the same patient doesn't make sense. So the government is saying that you should rationalize the manpower. The counselor for the NCD should also counsel for the tobacco cessation and vice versa. So that transition is happening, and because of that, the number is not exactly as the number of NCD clinics or the number of districts supported by NDCP. After this, we had also started, I look after National Oral Health Program. Then I realized that the dentist who examines the mouth of the patient, they could be the first people, who see the stains of tobacco in the patient, and then when they operate on the patient, they have usually about 30 minutes or so, and then sometimes they do it quietly without even talking to the patient. And then I realized that if we use this 30 minutes on counseling a patient who is on a dental chair, whose mouth is open, and he will not answer back anything because his mouth is open for the procedure, and he's all ears for you because he's in pain. And if you tell him that I'm going to do RCT for you, I'm going to do this implant for you, which is a very costly matter in some cases, then if you tell him that the implant or the RCT is not going to be successful if you don't quit tobacco, the person from tomorrow onwards, he will at least try to quit tobacco for that reason. Then if you tell him that, these lesions which has come up in your we call it oral potential malignant lesions, which has submucosal fibrosis, because of which you cannot open your whole mouth. If the dentist noticed that and says that because of tobacco, mostly the chewing tobacco, you are developing the oral submucosal fibrosis, which can turn into cancer. Then after some time, we have to cut out the whole part of your face. And if you don't quit tobacco, that person will be that scared and he will quit tobacco. So because of that, we worked on that potential, and with the Dental Council of India, we started trying to establish tobacco cessation centers in all the dental colleges in the country. We have about 302 of them. With the pandemic little becoming better, we would be monitoring the quality of these dental centers, the tobacco cessation centers in the dental clinic as well. And then, as I said, we have got about 5,000, NCD clinics, which till now has been doing mostly the clinicals, and we do have the provisions of NCD counselors. So we would be linking with them for tobacco cessation counseling. Pratima will tell you more of that. It's a spectrum, so from brief advice to very comprehensive advice. But wherever we fit in, whatever services we can provide at any point of time, at that contact point when the patient drops in that health facility, we would be doing that. So linking with the NPCDCS program, the NCD program for counseling through the NCD clinic is one which we are trying to offer again. Similarly, we have got the TB tobacco collaboration, where the DOT center, when somebody comes in front of the DOT center, the person thinks about TB. So he should also think about tobacco. Tobacco also, can cause, cough. And then when a tobacco cessation, a tobacco user drops in at the tobacco cessation centers, and he's never thought of the TB symptom. The counselor doesn't ask anything about the TB symptom. So we are all fixed into what we have been told to do. So we are trying to open up both the areas in the adult center as well as the TCC. So you can imagine the number of, the tobacco cessation services which can be launched from the numerous adult centers in the country. So that way we are also planning to. The other thing which is more powerful is the community-based, the population-based screening for NCDs, which is happening at the doorstep. The ASHA comes to your house. She does an enumeration of the family members, and if you are more than 30 plus, as she fills up the form, what is known as the community-based assessment checklist, and that has a history of asking for a history of tobacco user, alcohol user. So if a person answers that he is a tobacco user, we are trying to link. We have some issues. We do not have all the permission yet, but we have this potential that if the phone number of the person is there in the CBAC form, and the moment he says yes to tobacco use, he can be linked digitally to our Quitline and others. So, and of course, we have got the Quitline and we have got the M cessation. So in India, I think O is a very, very big component which we have developed in the last 3-4 years. Thank you.
Yes, sir. So thank you for the detailed situation, the large spectrum of tobacco services that are actually happening in the government sector. It also leads us to work closely with the government sector. We are much aware that the National Tobacco Control Program has been institutionalized with the main objective to ensure effective implementation of the provision under COTPA. So what is the larger outcome that you see with the cessation program is what we'd like to ask.
Yeah, that's something which I have been really wanting to do to record the cases in a digital form, the kind of an MIS form. Every time when we want to answer this question, we have to go back to the state government and ask them to tell us what exactly has been the number. So we have developed an MIS and we are trying to populate that MIS through the system. I think the ministry is going to launch that soon. Before that, we have a way of collecting it through our paper-based reporting. So I am told that about in this about 500 TCCs, around 20 lakh these customers, we should say the clients, have been there in the tobacco cessation centers in the district hospital. Then at the same time, Pratima knows more of this. The Quitline, we have got about 2.5 lakh calls per month. So that's a huge number which we are not able to cater to. Some percentage of it always left out. So that's why we are trying to augment the services in some way or other, so that we are able to either digitally we augment it or through a system, so that we don't lose anybody who has picked up the phone and called the Quitline, because that step of picking up the phone and calling is very, very important. If we lose it, I fear that many of them will not call again. So that is one challenge which we are facing, but those are the numbers which I have as of now. But we are trying to do it more accurately through MIS.
That's it. So with this recent COVID pandemic, we have seen that there may be a probability that COVID has on the respiratory system, and the impact of tobacco on the disease really concerns us. And of course, there are not so many peer-reviewed studies in India that have evaluated the risk of COVID-19 infection associated with smoking. So considering that there is this close association of COVID with tobacco use, we would like to know has there been a change in the approach of cessation centers and the response of tobacco users or clients, as you call them, during this whole COVID pandemic? So could you just throw a little bit of light on that, sir?
COVID-19 during the peak of the first as well as the ongoing second week, paralyzes everything. It just overwhelms the system. We should know that. And then saving lives, providing oxygen, providing hospital bed, providing ventilator and ICUs, that becomes a priority during those few weeks or days. Now we all have seen, we all have gone through that. We all have seen that. But what usually happens is after that peak phase is over, or before that peak phase comes, many of the health facilities are engaged with many of the COVID-related activities, like containment zone and the contact tracing, and the whole district administration is engaged with activities of the activities of the pandemic. I have been part of the central team during the COVID pandemic for about 4 or 5 times, and I used to go along with the health worker in the field. And then I used to see what actually they do in the containment zone. They go to house, and then they ask about how many members are there and how many. Then from the NCD point of view, I was also trying to see whether they ask if the family has somebody who has hypertension or diabetes or suffering from cancer, because those are the people whom we want to protect if they have not been affected yet. And then I asked them, do you ask for tobacco as well? Do you ask for alcohol as well? Because the disease is one, the risk factors is one. But practically, if I ask them, then they will ask. But I'm sure that that comes at less priority during those pandemic. So the COVID had and continues to affect many of these many of these services for NCDs, as well as the risk factor of tobacco or alcohol. And I don't think that many very active activities happens in many of the states. But however, from the central government, we have been trying to emphasize the negative link between a tobacco user, especially a smoker, with the outcomes of COVID-19. And we have been engaging the states with lots of IEC material. We have communicated through our social media handles. We have also requested the state government to do it on their own. So those were the activities which we are doing. But cessation, I think Pratima will also tell us, many of our Quitline centers, just for the mere fact that in the previous pandemic, the first peak of the pandemic, during the lockdown, it was not possible for our counselors to come and sit in the Quitline center, and they were trying to do whatever possible from the mobile phones, which sometimes will definitely be compromised than a normal day of working in a Quitline center properly. So this had been the story. But we really do not have the exact picture. I think once we are a little settled down, then we may try to look back to what has happened, and that would be a learning point for all of us.
Thank you, sir. Thank you. But there are a lot. We'll come back to you, sir. It's not yet done. There's so many questions that come to our mind on your engagement with the government, and I'm sure we come back to you, sir. But thank you for the insight for now.
Next, we would like to ask a question to Dr. Pratima Murthy. Dr. Murthy, Dr. Swasti just mentioned about Quitline services, and he was referring to you that, so we are talking about this Quitlines. So can you give us some insights about the Quitline service by taking us through a typical call? Like what happens from the point of time when a caller dials the Quitline number? Can you tell us the behind the screen story for that?
Yeah. Thank you, Rimanshu. First of all, let me compliment both you, Monique, and the rest of your team. I mean, it was so fascinating to hear about the work that you're doing and, the kind of positive, impacts that you're getting. You also mentioned that O was an orphan, but tobacco cessation in the context of tobacco control was also a bit of an orphan. And it's actually very exciting now to see that so much has occurred in the area of actually helping people to quit, and that this year's theme is on commitment to quit. Now, going back to the Quitlines, just to give you a little bit of a background, because I'm sure everybody who's listening may not be very familiar with how they were kind of set up. And as was mentioned, the idea was that just having an end cessation program, which is giving people SMS messages, is one thing. It has a huge public health reach, but a lot of people want to talk to somebody at the end of it. So I think there is a huge amount of value in human interaction, and therefore having counselors to provide this, especially in underserved areas and to underserved populations, is very important. So that was the idea, and it was initially started in the Vallabhbhai Patel Chest Institute in Delhi. And a couple of years later, now we have tobacco Quitline services at NIMHANS in Bangalore, at the Tata Memorial Hospital, and the Barua Cancer Center in Guwahati. And of course, I think all of you know that it's 1-800-112356. What happens is, so the call lands up at what is called the MTNL, And then depending upon the language that the person speaks in, it is directed to the various regional centers. So for example, in Bangalore, we cater to the southern India. So all languages, let's say in Malayalam, Kannada, Tamil, Telugu, will land with us. Of course, we also get a lot of Hindi and English calls. So typically when a person calls, the counselor will get some initial information. Now, of course, we've kind of computerized it so that's easier to get all the information, including why the person is called. So initially, a lot of our calls used to be queries, people wanting to know about somebody else who was having a problem. We also had some bit of Quitline bombing by people who asked and thought it was, asked if it was, we were offering some gold coins for people who called. So this was obviously a ruse from, from other parties to kind of, telebomb it. But important thing is over the time that a lot of people are actually calling to quit. So once they register to quit tobacco, what happens is the counselor has already taken some information about that. So the counselor helps them to set a quit date. And then the counselors also make what are called proactive calls. So one is the reactive calls which the callers make to the quit line. The other, the proactive calls which the counselors make. So the counselor will call them on the pre-quit date, tell them how to prepare for the quit date, call them on the quit date to check how they're doing. And then there will be regular calls a week, a month, 3 months, 6 months, 9 months later. So that's something that we do. And in the process, what does the counselor do? The counselor motivates the person to quit, discusses the positive aspects of quitting, discusses the fears that the caller has about quitting, gives them some tips to prepare in case they should have craving, they should have withdrawal, they should have mood changes, very simple tips that anybody can incorporate anywhere. And then leads them through, how to get rid of tobacco, material related to tobacco in their vicinity, how to share with others that they're going to quit, what to do on the quit date, how to change some of their thinking about, what worries them in terms of quitting. And that kind of carries on. And if people are not able to quit, the counselor also encourages them to try again, because all of us know that tobacco addiction is something that's very severe and people sometimes need several attempts before they can actually quit. And if the person is simply not able to with the counseling, the counselors may also refer them to the TCCs that Dr. Swasti mentioned, if they're available in different parts of the country. So we have a listing of all the cessation centers that are available to people. We also provide that. But the majority, most of the focus is on counseling people on an individual basis.
Okay. Thank you. Thank you for taking us through that interesting process. Something which we would like to know more from you is about the numbers. Dr. Swasti just gave us the bigger numbers at a higher level. But if you could go into the details and talk about the number of callers so far, or how many have gone through the entire process, or to give us an idea of what is happening, what has been the outcome, and also somewhere to talk about the change during the pandemic. Again, Dr. Swasti referred to it and spoke about how things changed completely, not just for the physical cessation centers, but also for the Quitline. But if you could just give us some details about that also.
Yeah. So Dr. Swasti actually mentioned that we are not able to service a large majority of the calls. So even though the calls land, the number of calls that the counselors can take is fairly limited. So now we're trying to see how we can link this up with the cessation so that, there can be at least some messaging that can go out to people while they're waiting to speak to a counselor. One of the things that has happened between the pre-COVID and the COVID is that also, although the number of calls landing has reduced, a large number, the proportion of people who call and register for quitting is much higher. So the total number of calls, although they've reduced, the number of interested and serious about quitting has increased. And the majority of the callers calling during COVID, we actually looked at the first wave, were because almost 90% of them were for health concerns around COVID, to reduce the risk from COVID. And of course, people who were at home during lockdown, they were worried about exposing their children, for example, to tobacco smoking. So that was very, very encouraging. The other thing that happened during the COVID is that also the number of people who actually quit In fact, it's phenomenal that on the quit date, as many as I think almost 3/4 of people who called actually said they had quit on the quit date, and nearly about 40% had quit by 1 month. Said that these were self-reports, of course. And this is almost like double what we would normally see in the pre-COVID time. So it's been very encouraging that more people are definitely trying to quit, but we need to support that through whatever resources that we have, because it's a very, very nice opportunity. I mean, you have to look for opportunity in every crisis. And COVID presents an opportunity for the millions of people in our country who are using tobacco, both smoking and smokeless forms of tobacco, to give up the habit and to commit to quit.
Thank you. That is really, like, the numbers are really encouraging, and it like motivates the rest of us also to work towards this. And I'm sure all of this has a lot of training and coordination that has gone into it, in addition to the technology that is helping us out.
Yeah,
So,
I must
Dr.
tell you
Murthy,
one thing, Himanshu, that,
yes,
for example, during COVID, our counselors were also at risk, right? Because they had to come and so on. So one of the fantastic things that actually happened is that our counselors shifted from the center-based counseling to counseling at home. So we were able to exploit technology to make sure that whatever calls landed at our center were diverted to the counselors, and the counselors were able to run it at home. So I think that's again a beauty of what has been happening in terms of technology.
Right. Thank you. Thank you very much. So, Dr. Murthy, will come back to you with some more questions.
Yeah. So now, thank you, Rimanshu, coming to Dr. Prakash Gupta. So foremost, we want to congratulate you, as we found some information about you, and it says that you have been recognized as one among the top 2% scientists in the world by an independent study done by Stanford University scientists. You're the only person to be recognized to have meaningful contribution to public health in India, and are ranked as 185th globally for the impact in this field. Of course, we didn't need Stanford to tell us that. We absolutely acknowledge your contribution. Your work in smokeless tobacco use is well recognized in the world, and thus you also lead organizations such as Narottam Seksaria Foundation and Salam Mumbai Foundation to therefore monitor the problems of smokeless tobacco and understand its possible consequences on public health. We would like to briefly know from you about tobacco cessation in the context of smokeless tobacco, sir.
First of all, thank you very much, Monique, for your very, very kind words.
Yes.
And I do want to appreciate and acknowledge the excellent platform that you are building for interaction with everyone who is interested and active in tobacco control. Now, you have touched upon smokeless tobacco, and that, of course, is a topic that is extremely close to my heart. And it is a very specific topic, very specific problem for India. Although by now, with lot of efforts, we know that the problem exists in many other countries, although it is not as big as in India, and it has not been so well recognized. But the problem exists. So it's a global problem, but biggest uh, effect is in India. So now let us see how do we deal with this smokeless tobacco problem. It's a difficult problem to say right in the beginning, because first of all, unlike smoking, which has only very, very few kind of appliances and products, in India it's mainly bidi and cigarette, and then there are some water pipes or chillums and cheroots. These are about all the products for smoking, and recently, of course, vaping products which have been banned. But for smokeless tobacco, the spectrum is very wide, very huge. Number of products are available. They vary from place to place. Their prevalence varies from place to place. Their method of preparation and method of use also varies. For example, there are products that are industrially manufactured, just like cigarettes, by big industries and advertised and sold. And we all know about gutka and similar products. And then there are products that are manufactured on basically in cottage type of very small industries. That's like BD in a way, but at a smaller scale in a cottage industry. And then there are products that can be made at home. Then there are products that are made by vendor. You go to a vendor, we all know there are vendors all around. You go to a vendor, ask for betel quid with tobacco or any other tobacco concoction or combination you want, and he prepares it as per your order and gives it. And then there are many products that user himself or herself makes, and that proportion is very large in India. People take tobacco flakes and add some select lime and areca on that and whatever else they want, and then they use it. So the whole spectrum of products and methods of use are have a wide spectrum that creates an issue about the control of the problem, and issue about cessation also, because every kind of use has a different kind of its addictive potential and different kind of behavior pattern. So all that comes into play when we think about cessation. Now, how are we doing about cessation and smokeless tobacco? No, when we want to look at population-wise whole of India, one thing is good that everywhere those who are working on tobacco control in India, I mean, you are all doing that. Most of the audience people are doing that. When we talk of tobacco, we include tobacco as a whole. Unlike many countries, we don't restrict to smoking. So we also include cessation of smokeless tobacco use along with smoking, and that's extremely important for India. But how are we doing? On the whole, I think we are in the right direction, doing reasonably well, because you compare the data of Global Adult Tobacco Survey 1 with Global Adult Tobacco Survey 2, that's about 5 years apart, there is a decrease, a reasonable decrease in the prevalence of tobacco use. And that's a very heartening, very good sign. And when you look, break it type of use, by the type of use, we see that there is a reduction in the prevalence of smoking as well as of smokeless use. But then you look a little further and you realize that the reduction in smokeless tobacco use, the percentage reduction in the prevalence of smokeless tobacco use is much lower than that of smoking. So it shows that what we have been able to do with the smoking, we have not been able to do in the same way with the smokeless tobacco. And we have a lot more to do. Also, a very encouraging point in our Global Adult Tobacco Survey results in 2 survey, there is a very substantive drop in the prevalence in very young age group. In fact, in minors, it is very huge, and even in the youngest age group of 15 to 24, it's a drop is much larger, reduction in prevalence is much larger than the overall sample. So that shows that we are doing reasonably well in terms of delaying initiation. Not many adolescents and young adults and children are picking up tobacco habit, not as many as they were doing earlier. But in the older age groups, the difference becomes much less. And that shows our lack of performance in that part, that our cessation rates are much lower. We are doing well with respect to reducing initiation, but not as well in terms of cessation. So, looking at the data gives us these kind of pointers where we have to do more, where we have to put more of our efforts. And smokeless tobacco really comes out as one specific area in which many more efforts are required, not only in terms of cessation, but also in terms of entire tobacco control strategies. So I hope I answered your
yes, sir.
query.
So that, in fact, pushes me to deep dive a little more. where so we understand that the consumer who is using tobacco which is smokeless and smoking tobacco, but both these people may not be the same, and therefore it brings us to the question that since there's not so much research either on behavioral aspects in smokeless tobacco cessation in India, does nicotine replacement therapy play a role in smokeless tobacco cessation, sir?
That's a very interesting, very important question. Unfortunately, we don't yet have answer to it. I mean, there is a lot of research in the USA also, but uh, it's the results are unequivocal. Can't say that NRT definitely helps in the same way for quitting a smokeless tobacco as for smoking. In India, unfortunately, I don't think there are many randomized control trial that provide answer that can provide answer to this particular question. Certainly, there may be in the clinic-based studies with lot of behavioral intervention also, but not in any kind of population-based study. We have not seen any results. So it's not to say that smokeless NRT is completely useless, but I think much more work is required to say that it is useful and how it can be made use of in smokeless tobacco cessation. Another problem with the smokeless tobacco cessation is that unlike for smoking cessation, where there are objective parameters, there can be easy test. I mean, salivary cotinine test and blood cotinine levels, those are standard all over the world, but then those have been reduced to like strip tests, commercially available strip that can test nicotine in the urine or in saliva. Those unfortunately don't work as well for smokeless tobacco. So we have a lacuna even in that respect, that if we do a trial on a smokeless tobacco cessation and we want to show the result, we really don't have objective test. We have to rely only on the self-report. So those are some of the kind of limitations of current scenario on smokeless tobacco.
Thank you, sir. Thank you for the wealth of knowledge. The conversation with you is never enough. So we come back to you with a little more of thirst for the knowledge soon, sir. Just a little more time, sir. Thank you.
Guys, we just have heard about smokeless tobacco from Dr. Gupta. And when we talk of smokeless tobacco, we are often reminded of adolescents who get initiated into tobacco use through smokeless tobacco. A lot of times that is their first tobacco product. So our next question is about tobacco use among adolescents. And this is to Dr. Upendra Bojani, who has worked extensively on adolescent tobacco use and policies related. So Dr. Upendra, we would like to know what are the cessation related policies and what are the interventions that are being implemented currently in India for adolescent tobacco cessation.
Thank you, Dr. Rimanshu. And first of all, thanks for having me. I feel very humble in the presence of my mentors on this panel. Also, there are many citizen experts, Dr. Murthy, Dr. Vikram. I'm quite a generalist, really, in tobacco control. But I feel there has been a lot that has been done, particularly in past decades, to expand the spotlight on citizen and citizen services. And I think Dr. Pratima Murthy already elaborated a bit on specific aspects or specific modes of providing citizen care. I mean, there are many, there are several policies. If we really understand policy in a broader term, not necessarily focusing only on youth. I mean, many of these policies have been more generic in providing citizen care. And I think Dr. Swastikaran also highlighted how, as part of both the National Tobacco Control Program, there are district level provisions for tobacco citizen counseling. There is guidelines around tobacco-free school and educational institutions, which can deal directly with youth and adolescents. And then there is Quitline, there is cessation. I think there has been really a deliberate expansion and focus on cessation in India in the recent past, which is really a very welcome initiative. There are, of course, there are legal measures which one may not see as a cessation sort of measures, but which are the measures which either promote young people, either prevent them from the uptake or sort of promote users to go towards seeking help. And the Cigarette and Other Tobacco Products Act particularly prevents tobacco sale by and to minors and around educational institutions. There is now Quitline number, which is being printed on as part of the petrol health warnings on tobacco product specs. So there are many things which are being done, I would say, including many legal measures, many programs. Whether there is a specific focus on youth, there is some focus in some of these initiatives, but I think certainly there is room. There is room to do more, and there's room to do more for young people particularly. And I think schools are probably the best setting to sort of do more and provide more effective citizen services. If I take one more minute, I would like to share recently sort of we engaged in evaluation of a school-based tobacco and supari citizen program, which is Life First, a co-organizer of this event, which is being run by Narottam Sekhsaria Foundation and Salam Bombay Foundation. We did a COSI experiment study. This program is being provided to students in corporations and schools in Mumbai for quite a few years now, and we used an experiment where the students in intervention schools received this nearly kind of a year-long program with many group-based counseling sessions, and control schools where students were registered for the program, but they would receive the program in a subsequent year to avoid sort of ethical dilemma. And so it provided kind of an opportunity to really study the impact. And we just sort of got this paper published in a population medicine journal, which has very encouraging results actually. It shows that we use a difference in different sort of design to see what is the real change among intervention students over time. And we see that nearly 18 percentage point reduction for tobacco use among those students who were in intervention schools who received the Life First program. And there is even higher, nearly 38 percentage point difference reduction in the supari use prevalence among students in intervention schools. I think, of course, we can do more in terms of optimizing school as a setting to provide citizen care, which particularly will help young people. But I don't think we are doing enough in that respect. I mean, we have very limited evaluations, very limited documented programs. But whatever has been done, we see some encouraging response. I do remember Dr. Prakash Gupta and group who evaluated a similar program around school teachers, and it showed its own positive impact in reducing tobacco use prevalence among teachers. There was a Murthy trial earlier in India, which again had an encouraging result about reduction in tobacco use among school-going students in Chennai and Delhi. So I think maybe we should sort of optimize schools as a setting, and there are already school-based components within National Tobacco Control Program, and there are many things being done to create more tobacco-free environment in this setting, which is worth then complementing with bit more sustained and focused citizen support to young people. I must provide a caveat that this Life First project evaluation findings that I talked about, that program particularly aims students who are already willing to quit, right? So the students register willingly, and that may not, these findings, so much encouraging results may not come when, of course, you are targeting a general youth community. But I think what I'm trying to highlight is there is a room to do much more youth, bring a lot of youth and adolescent focus in the area of tobacco cessation.
Right. Thank you, Dr. Upendra, for those insightful facts and your opinions, and also thank you for referring to Life First. We will come back to you again with a few more questions.
Moving away from the adolescent group and the school group, I think we have one more important stakeholder group, And that draws us to Dr. Vikram Mohanty. This is the oral health professionals. Dr. Vikrant Mohanty has been in the forefront in bringing tobacco control as a part of the dental academia. So how do you envisage the role of oral health professionals in tobacco cessation? We have heard about the mandate from the Dental Council of India about having tobacco cessation center in each of the dental colleges. So how's that program rolling out? So we would like to know from you.
Yeah, thank you so much, Dr. Monique. First of all, I would like to congratulate all of you for setting the stage with such an important topic, because many of us talk about cessation in general, but what you have actually brought into this platform is talking about not only the practices, but also the challenges, as well as what are the gaps that are there in, and how we can work towards bridging this gap. And I congratulate all of you for doing this great job. And Life First is surely a great initiative, and I have seen results personally, and I congratulate you for that also. So coming down to this, what you just touched upon, tobacco cessation, I always have asked this question: whose job is it to do tobacco cessation? So this question, it can be answered by a dental professional, it can be answered by a medical professional, and many other healthcare professionals working in the arena could be trained and oriented towards this rendering such services. But when it came to dental care professionals or dentists, this has been a long association, and I'm very sure Professor P.C. Gupta will agree that how dentists have contributed in research over the years. Sir knows, I have heard Sir speaking that over almost, I think from 80s onwards, dentists have been associated with Sir in all his research work. So that itself shows that the oral cavity being so accessible allows us to actually without breaching the privacy of a individual, we with just a consent, we can examine, identify, and develop personalized strategies. So that itself is the first step, that we are already very close to the patient, and we always stand a very unique, we are in a very unique position. Dr. Swasti already elaborated how dental professionals use the chairside time as a teachable moment, that we call it, and how that time can be used when the patient is all ears to you. And so these are opportunities that we see. And as I think Dr. Rimanshu said, that offer cessation has been orphaned, but we have looked, not, I know the control side has looked at it as often, but we have looked at it as an opportunity rather than being orphaned. So this opportunity was utilized, and I think way back in 2018, this whole process was started off, where the Dental Council of India and the ministry came together with a small group of stakeholders from the WHO, from the medical, from the dental fraternity, and constituted this group, as a result of which this guidelines, with operational guidelines, were laid down. That was in 2018, and by the end of 2019, the Dental Council of India actually rolled out this and implemented this across all the dental colleges. It is, we have 313 dental colleges in India today, and all this was implemented with just one directive from the Dental Council of India. Following this, the Dental Council of India actually followed up with these dental institutions for a compliance report. And as of now, out of 313, we have around 302 compliances reports with the Dental Council of India, based on certain parameters which they had laid down with regard to based on the operational guidelines, because the operational guidelines actually lays down not only the infrastructure requirement, the components that would be there within the clinical settings, as well as the human resource that is required for establishing the cessation clinic. So all this compliance report was collected. As of now, they have 302 compliance reports. That is one thing with regard to establishment of tobacco cessation clinics in dental colleges. The next thing was that we initiated the World No Tobacco Day. Every year has been organized. Again, the letters were shot out to all the dental colleges to make it mandatory that they observe this day and simultaneously submit an action report taken during this World No Tobacco Day. So that was one more thing which was in line. Following that, the Dental Council of India incorporated the tobacco cessation clinic as an integral part of the assessment. That is, the Dental Council of India regulates the educational standards in dental colleges. So as a part of that, they have a standard inspection pro forma, in which the establishment of tobacco cessation, the number of patients visiting the cessation clinic, as well as the staff, and all that was laid down in the annexures of the inspection proforma, and it made it mandatory that every visit by dental council inspectors, they would visit the tobacco cessation clinic and actually assess the clinical setting, whatever they're doing there. So this became a kind of a, I would say, a kind of an approach that we have been pushing forward to. I know this is not enough, but at least this much has been done. If you look at the other streams, we still have to get information from other healthcare, streams, from the medical colleges, from the nursing colleges, who will also contribute to a certain extent with regard to establishment of cessation clinics.
Yes, sir. Thank you. Thank you, sir. And so thank you for being so open about gaps and successes of intervention. As you know, sir, with all these experiences, Life First has also collaborated with 10 dental colleges and regularly conducts training programs and has also nudged and helped the college administrations to initiate tobacco cessation centers. In our experience, the training at the dental colleges has been overall positive. Yet we are curious to know about more gaps in rolling out these cessation programs. So what are the identified challenges that you see, which probably lack of follow-up of cessation with patients, and how do you think all these challenges can be addressed at the service, at the service level at the dental colleges?
Yeah. So with regard to, see, the challenges are always, no services without challenge in our country, because, we have many things to deal and always are short of resources. So, and that is always the time and the resources, always a struggle goes on. But when you look at institutional level resources, there are many things. Actually, we just, as you know, that, we just had the first national webinar last year in 2019, wherein we invited all the dental colleges for this, the first national webinar on integrating tobacco cessation clinics services in the dental colleges. And we almost received some 248 responses out of the 313. 248 actually responded to our status report of the cessation clinic. And on the basis of that, there also we had questions regarding challenges. And the most common challenges that came out, one of which you have already mentioned, is the lack of necessary follow-up. And other than that, challenges which I would just like to mention here before I go on telling you about the solutions, was that one was on the basis of the lack of follow-up. Two was the availability of trained human resource, which was short. And three was lack of adequate funding for such, even running such a cessation clinic would require some basic funding. And that also was short, because, dental colleges, 313, more than 80% of dental colleges are actually private owned or private run colleges. So their focus towards this, rendering cessation services, I'm not saying questionable, but still has to be taken up with a pinch of salt. And we need to work on that aspect. So funding is surely one issue. Again, time and motivation of all the people who are working, and follow-up, fallout is a big issue. So when it comes to follow-up, what our experience has been is that we, most of the patients do not walk into a dental institution like ours for dental. They walk in for dental care. They don't come asking that I want to look for cessation. I'm looking for cessation services. Yeah. So that's the first thing. So what do we do is, when the first screening is being done, this patient is identified, and as a part of the strategic referral system, he is referred to the cessation clinic. And once he falls into the loop of the cessation clinic, it is established during those initial conversations that his treatment will be continued. The cessation follow-ups will be in line with his treatment. So whenever he visits the dental hospital for his dental follow-ups for his treatment, he visits the cessation clinic as a part of that. And that is the most that we can think where in-person follow-up can be done. Though there are other strategies which we have used, and we have also published a few papers on that, is the use of text messages and follow-up, phone calls. So during COVID-19, when the first wave actually hit, we had almost, it was in March. So we went back in time from January to March to see what our patients who are registered, how has been their status for the next 3 months, from March, April, and June, May. We saw their status and we tried to see whether they had quit the habit and what all the problems that they were facing and how did they cope for that. So it was very nice that the response on the telephone itself was good, though it was just a one-to-one, one-time conversation of 10 minutes, but a very structured feedback was given by these patients, and many of them thought about quitting. Yes, there were a few who still said that once the lockdown opens in the first wave, were very willing to go and buy these products. So these are certain issues. So telephone-based, text messages, integration with dental treatment, these could be the best ways of, from the dental perspective, I would say would be good to integrate and improve the success, other than integrating behavioral intervention as well as pharmacotherapy in it.
Thank you, Dr. Vikrant, for the guidance and the lead to include oral dental practitioners in tobacco cessation. Based on your findings and research, definitely will improve our own programs and lead us to have greater involvement with the dental institutes and practitioners. We come back to you, sir, with more questions. Yes, Himanshu. Yeah, thank you. Himanshu, over.
Yeah. Yes, let us now talk about tobacco control within workplaces. So we have with us Ms. Manisha Khairnar from Ambuja Cement Limited, Surat plant. She was involved hands-on in the tobacco cessation program at the plant. So Manisha, you represent a plant here that has launched the tobacco-free workplace initiative. Your plant is based in a region that is known for its high tobacco use. So can you share what were the activities that were conducted within the plant, what are the current steps that are being implemented to sustain that anti-tobacco environment?
Sure. First of all, thank you, Himanshu, and thank you all panelists for such a wonderful discussions and interaction with all of you. So, as a working in a cement industry, we have a huge manpower, and especially in labor class people, they don't know, means they are very habitual about these smokeless tobaccos, and so it is challenging how to them educate and how to aware them, because use of the causes of the tobacco issues and problems. So we, first of all, we have started to interact with them with our Salam Bombay Foundation team. We met 2 years before back, and we have conducted the many sessions, and we have decided this activity in many levels. So first of all, we are started to checking at the security gate. First of all, when they are joining to job, they are coming to workplace, we are finding them at the gate level. और वही गेट लेवल पे हम लोग उनका चेकिंग करके उनके पास अगर इस तरह का कोई तंबाकू या इस तरह के कुछ पॉकेट्स या ऐसा कुछ भी उनकी जेब्स में मिलता है तो सिक्योरिटी वहीं पे उनको स्टॉप कर देती, और मे बी अगर कुछ थोड़ा बहुत रह जाता तो इनसाइड अगर वो प्लांट में आ भी जाता है. इन दैट सिचुएशन हमारा एक प्रोग्राम है कि टूल बॉक्स टॉक्स. टूल बॉक्स टॉक्स बेसिकली ये होता है कि कोई भी एक्टिविटी या कोई भी जॉब परफॉर्म करने से पहले वहां पे उस जॉब का एक एनालिसिस होता है कि इस जॉब में क्या क्या हजार्ड इन्वॉल्व है, किस तरह का प्रिकॉशंस लेना है, तो उसी को आइडेंटिफाई करके उसी को मिटिगेट किया जाता है. तो नॉट ओनली टेक्निकल साइड हजार्ड वी आर आइडेंटिफाइंग, बट जस्ट ये एक ह्यूमन हजार्ड है, जो अगर कोई तंबाकू खा रहा है या बीच में कोई तंबाकू की आदत है जो काम छोड़ के इस तरह का एक्टिविटी करने जाता है, तो बिफोर दैट उसको भी हम लोग उनको अवेयर करते हैं, उसके कॉसेस बताते हैं, उसके इम्पैक्ट्स बताते हैं, सो दैट वहां पे भी उनको एक अवेयरनेस सेशन मिल जाता है. देन सेकंड, एचआर इंडक्शन जब भी होता है, कोई भी न्यू ज्वाइनिंग होता है, देन एचआर इंडक्शन के टाइम पे भी उनको बहुत अच्छी गाइडेंस अवेयरनेस मिल जाती है. सो वहां पे भी उनका एक काउंसलिंग का लेवल हो जाता है. देन वी कैन से कि हर लेवल पे, जैसे प्लान फ्रॉम एंटरिंग टू शाम को वापस जब घर जाना है, तो हर लेवल पे इंटरेक्शन विद बॉस, इंटरेक्शन विद पियर्स, इंटरेक्शन विद कलीग्स, तो लंच टेबल पे या कैंटीन एरियाज में जहां पे भी वो जाते हैं, उनको हर तरफ पे एक टोबैको सेशंस का कुछ ना कुछ पोस्टर्स मिल जाते हैं कि कुछ इश्यूज मिल जाते हैं. कुछ पियर्स ऐसे होते हैं कि जो अपना सक्सेस स्टोरी शेयर करते हैं कि अरे यार मैं पहले कर रहा था, अभी मैंने छोड़ दिया, नाउ आई एम कंफर्टेबल, आई एम इन गुड हेल्थ. तो इस तरह का जो एक्सपीरियंस और जो एनवायरनमेंट पूरे प्लांट में हम लोगों ने क्रिएट किया है, so that is very good, and thank you for Rimanshu ji for such a wonderful interaction and awareness creation.
Thank you Manisha for sharing those implementation insights Just to add over here, Life First has been working with assisting workplaces like this Surat plant. We have been working with other factories, a lot of corporate offices. So we've had this experience and reached out to about 10,000 odd employees at different workplaces, almost 20 factory settings that we have worked with. And over this time, over this period, we have had about 2,200 enrollments for actual counseling within these workplaces. And of course, not to mention that a lot of them, or maximum of them, have been smokeless tobacco users. And what we found is after 6 months of counseling, taking in through the Life First protocol, a lot of telephone counseling was involved over here because the factories are far off. Not all in-person contacts can be made over here. What we saw that the outcomes, or again talking in terms of PPA, the point prevalence abstinence, was the highest among all our settings that we found in workplaces. It was almost 65 if you take an average of all the settings that we were in. And again, like we have analyzed this, and what we attribute this to is that it is because of the workplaces are a closed environment. There is a lot of positive peer pressure also. A lot of people have mentioned that they started using because of the workplace, which was sort of initiating, but while quitting also, that peer pressure is working and helping them to quit. And the most important thing over here is the supportive management policies. So they are supportive towards the workmen or the work women, or in some cases where they are actually helping them to stop their tobacco use. They are inviting us the program and providing counseling services over there, and also creating an environment which Manisha just mentioned, which actually helps people to quit their tobacco use.
Yes, sir.
Yeah, thank you.
सो सर एक स्टोरी मेरे सामने किसी ने शेयर किया है हमारे वन ऑफ सो वी आर एसोसिएट विद ड्राइवर्स आल्सो बेसिकली वी आर डिस्पैचिंग सीमेंट आउटसाइड सो वन ऑफ ड्राइवर शेयर्ड हिज एक्सपीरियंस कि उसका जो कॉस्ट है जो टोबैको जो प्रोडक्ट वो यूज कर रहा था और जो खा रहा था उसकी वजह से उसका कॉस्ट ऑलमोस्ट 7,44,000 something when he has started at his young age कॉलेज लाइफ तब से वो स्टार्ट किया था और आज तक का उसका जो है मतलब कॉस्ट उसने निकाला है तो ऑलमोस्ट 7,44,000 का कॉस्ट है सो ये एक्सपीरियंस बहुत ही अच्छा है उन्होंने अभी इसको ट्वीट करके एक एग्जांपल सेट किया और ही इज नाउ आवर एम्बेसडर ही इज शेयरिंग हिज एक्सपीरियंस विद अदर्स आल्सो सो ऐसे बहुत सारे सक्सेस स्टोरीज विद द प्लांट आपको मिल जाएंगे कि जिन्होंने क्विट किया है और आज दे आर वेरी हैप्पी टू लिव अ गुड लाइफ फॉर देम एंड देयर लाइफ देयर फैमिली आल्सो
करेक्ट नहीं these stories are always motivating. मतलब जब हम ये सुनते हैं even for a program हमारे जैसे it is motivating for us, and I'm sure it is motivating for the other employees at the workplaces, and we will surely take these stories and we pass them on to different factories and talk about these stories, which becomes a talking point and a motivational point for them. Thank you Manisha.
Thank you sir.
Thank you Rimanshu. So moving from real experience of Manisha, so this takes me to Dr. Gupta actually, and so we noticed that there are not enough sources testing some smokeless tobacco products, and all this testing has been a little ad hoc, and therefore there is a lack of comprehensive and periodic analysis of these products, and of course the impact and understanding of cessation practices that have to be applied, particularly in smokeless tobacco. Looking at the whole high prevalence of smokeless tobacco, so could you please let us know if there is some national level research on smokeless tobacco cessation carried out in India? And what would be a feasible recommendation on tobacco cessation for smokeless tobacco?
I thought your first part of the question was on testing of smokeless tobacco products.
Yes.
Now that's really a very, very important question. And as you said, there have been some studies. I have been associated with several of them, but there have been kind of sporadic studies, just testing few products that are available, and those kind of studies are still going on. But at national level, those were lacking so far. Recently, the ministry has started tobacco testing laboratories, and at 3 places. One is in Noida, Mumbai, and I think Guwahati. And those have just started or about to start functioning for testing these tobacco products. I think Dr. Sasti Charan has left, but he would be the person to answer this, because all the laboratories that have been developed are with his very hard work and involvement. Uh, then the question about national program of cessation, again, it's National Tobacco Control Program, and under that, whatever is happening includes smokeless tobacco. As Dr. Swasti Charan has said, and as Dr. Nirmala Murthy also, I think, has said. So there is no specific separate program as such for smokeless tobacco. But at this point, I would very much like to congratulate uh, NSF and Himanshu for one particular thing, which mostly, and also Upendra mentioned it, which is completely ignored by most persons, and that is areca nut. Now in India, we know that smokeless tobacco problem is very, very closely linked with areca nut problem. They are used together. They may be used separately also, and then there can be there can be a progression, as Himanshu had mentioned earlier, and it's a part of research paper also. So that is a kind of work that is extremely important. How we can wean away those children, especially who are just using the smokeless tobacco, how we can prevent the progression from areca nut, those who are using areca nut, and progression from areca nut to smokeless tobacco. And I'm so glad that NSF and Life First program are focusing on this particular aspect, which was on which there is very little information, and hardly anyone else has focused on this particular issue, which is specific to India. Areca nut is there in many countries, but this particular problem of areca nut leading to smokeless tobacco, I think, is and combined with the smokeless tobacco, is very specific for India. So thank you all very much, and congratulations on that kind of initiative.
Thank you, sir.
Monique, can I just add?
Yes.
Can I just add that we've done some work on looking at the nicotine levels in various forms of smoking and smokeless tobacco, and I've just shared a paper on that. There's a huge variation. We are NIMHANS, we also have a toxicology lab, which is a member of the TOB Lab Net of the WHO. So we are looking at smokeless products and their constituents in more detail, and we should be, the report should be out in the public domain shortly. But very important, because it's only then that you can actually tailor tobacco cessation interventions.
Yes. Okay. I'm sure, sir, with the recommendations coming from Dr. Gupta and from Dr. Pratima, it will largely help the group that is listening to the recommendations on this platform, because all of us here are people who are working towards tobacco cessation activities, and definitely when we will put these recommendations into practice, we will definitely find the necessary results. Now going from these recommendations over to Dr. Pratima, madam, we find that the evidence-based research for telephonic counseling is really inconclusive. And the effect of reactive telephone counseling due to limited number of studies is therefore, we wanted to guide us on these Quitline services and your experience in understanding telephonic versus face-to-face counseling.
Yeah, so the problem with face-to-face counseling is something that has already been discussed, that, people coming to these services, there is a lot of limitation in terms of, where you place it is very, very critical. And therefore, I think we need an expansion of those in different kinds of facilities. Now, in terms of, for telephonic facilities, I think there is a reasonable amount of evidence that they do produce change, particularly at a public health level. That's number one. The second thing is that the experiences of the Chest Institute initially and us indicates that these are very reasonably, again, pretty good quit rates. And I already mentioned the quit rates earlier. And that's very important. The third thing that's extremely important is that we all know that tobacco contains nicotine, which is highly addictive. And we know from a lot of experiences of people who are dependent on tobacco that it takes them multiple efforts to actually be able to sustain quitting. And I think, therefore, it's not just one or two calls, but actually keeping in touch with people for a prolonged duration of time till they're able to make some lifestyle changes to be able to give up is very critical. And that's something that we found in the initial phase when we started tobacco cessation facilities. We found that if you retain people in the treatment services, actually there are more number of quitters, who remain in services after 3 months or 6 months. So I think that's another very, very critical point, that it's not just enough to, respond to a person who's calling because, in the words of Mark Twain, I've quit 1,000 times before. It's the most important thing is to retain them in the follow-up service. So whether it's telephonic or whether it's Quitline, whether it's tobacco cessation clinics, you need to retain people in follow-up to be able to produce that kind of sustained change. But I think even if the numbers that we do get are hugely impactful in terms of public health consequences and reducing mortality and morbidity.
Sure, thank you. In fact, for us also, we completely moved to telephonic counseling because of the pandemic, and the whole counseling unit now is constantly engaging with patients and tobacco users. I wouldn't call them patients, but tobacco users on telephonic counseling, and slowly over a period of time with close monitoring and interaction, we find that we have very positive results, and of course it was also a new learning for us, but it has given us a very positive results.
And I think the clientele that you get in different fora are also very different. The clientele that you possibly can deal with is are people with milder dependence levels, and that's definitely very, very helpful in helping people quit.
Yes, that's true. Of course, I don't know, going ahead, how do we actually take it up as a service of choice versus the situation that we are in now, where we've taken and adopted it just as a modality of adaptation to the situation. That remains to be seen, of course, and we hope that many people can benefit, because telephonic is no doubt a little simpler than face-to-face, and it gives the confidentiality that is required as well. Thank you, Dr. Pradima. And moving on from there, I think, Rimanshu, if you have some more questions.
Yes, sure. So I would like to come back to Dr. Upendra. So just like mentioning over here in one of our previous conversations, you had mentioned that tobacco cessation has to become a right. Yeah, so especially that conversation was in the context of maybe adolescents. We can talk of it overall also, but especially when we talk about it in the context of adolescents, like looking at tobacco cessation as becoming a right for every child. So how far do you think we are from there? Like what are the gaps in the systems or gaps in tobacco control itself, which need to be addressed for reaching this? And what would be the steps that would be required to take for us to take to strengthen the cessation services for adolescents especially?
Yeah, thanks. I think, as you can imagine, my co-panelists are much scholarly in terms of the pre-addiction science and kind of experience they have in cessation. So let me use this opportunity to rather bring some generic concepts in tobacco control that I feel can help in this area, and particularly focusing on young people. I feel, one, while a lot has been done and improved in area of providing cessation services, there is a lot more room to do much more, both in terms of science of it, but also in terms of enhancing the provision. I think Dr. Gupta highlighted the complexity of when you have to deal with different kinds of tobacco products and cessation services around it. Similar complexity can also be imagined when we talk about different kind of user groups, right? At IPH, we work with Soliga tribes in a forested areas of Karnataka in Chamarajanagar district, where one of the perceived problem of the community is high tobacco use, and there has been some sort of community activism around it. And now there is clearly a demand for service. And one despite a lot of service provision otherwise in society, one wonders whether those models will readily suit to this particular group, and it doesn't really fit into it. So we need to learn a lot more from the community members to see what kind of adapted platforms we need to put in place, working with community that would lead to more acceptable provision of citizen services. Also, how do we scale the current citizen services which are available? How to really, why it's, I know it's very easier to say integrate, and I really appreciate that, but I think if integration, I just wish it was easier to do, whether it is in school systems, whether it is in health systems. We still have a lot of studies showing very high willingness by healthcare providers to do tobacco counseling and to do tobacco citizen. But if you look at the actual experiences of citizen service delivery, it tells you another picture, right? So I think there is a lot more work that needs to be done in this particular area. But I think an attitudinal change is also needed among many of us who engage in tobacco control in general, in country and in our own sort of communities and areas where we really see tobacco cessation as a right. I think there is a growing body of sort of discourse around using the human rights-based approaches to tobacco control. I truly believe that such a view towards tobacco control also help us navigate some of the difficult paradoxes and contradictions we often encounter. You know, doing tobacco control, is it anti-farmer? So there are many such dilemmas, which I think using human rights approach to tobacco control help us show some light. I think particularly when it comes to youth, one point I really wanted to bring up is that more and more often, if you just look at the kind of debates and discourse that has happened in India and generally around the world in tobacco control, youth are particularly seen as victims, you know, and at best as targets for tobacco control programs. Now, of course, there is some truth to it. I mean, we do know that the tobacco industry particularly targets youth. They are certainly at higher risk of getting into addiction. They are vulnerable section of community for sure. But there is much more. We need to look into youth and adolescents. They are also the change makers. If you just go by limited science we have available at our hands, it also says that while, just like Rimanshu highlighted in the workplace context, that the workplace and the work peers often leads to uptake of tobacco. Similarly, peer influence has been one of the major factors in youth uptake of tobacco. But at the same time, if you look at evidence around interventions which are dealing and targeting youth, you also see the same thing, that the interventions which have components of youth engagement, youth-led advocacy, are much more impactful in terms of reducing tobacco use among youth compared to those which are more passive, which don't really lead to a lot of engagement of youth in this program. So I think one thing if we need to do is really to see youth as just beyond the victims or beyond the targets of our tobacco control programs to really the change makers, and how do we engage them even in such fora, right, to talk about tobacco control. Because I think having worked with school students, one of the most common questions I have come across is, if tobacco is so bad, why don't government shut down the tobacco factories? And that question still dreads me. You call it a naivety of youth, or you call it, or you feel pity about our own helplessness. But I think we need much more younger voices and the room for such younger voices in our tobacco control movement. And I really appreciate some of the leading names and mentors like Dr. Gupta, who actually encouraged people like me and many others in tobacco control at a time when I can now see we were very naive. But I think probably they nurtured a whole new sort of generation and voices for tobacco control in India. And I actually wonder, we should be doing much more in those respects. So I think that sense there is a lot more to do in area of particularly engaging youth and certainly improving citizen, but also in general tobacco control practices around youth.
Right. Thank you. Thank you very much. Yeah, that is a very important point. Involvement of youth for the youth is what is required, and we should focus on that. And Yeah, we know there are certain initiatives which are already have been doing this or doing this presently, but more of that is required. So thank you, Dr.
I mean, if
Upendra.
you look at other social movements in health, which have been particularly impactful. I mean, if you look at HIV and HIV patients mobilization, I mean, the clear message that rings in ears: "Oh, nothing about us without us." And we don't see so much voices from those who we believe are at risk of tobacco addiction, or those who believe are tobacco users. I mean, where are their voices? We have somewhere not done enough sort of to keep them on board and to actually have them guide the tobacco control movement.
Sure. Yeah, so your point is well taken, and we should look at it from that perspective. So thank you, Dr. Upendra.
Thank you, Rimanshu. So knowing from Dr. Upendra that there is definitely a gap, and and in the lens at which we look at tobacco cessation, we need to look at it from the rights-based lens, is what we understand from using. And we also notice that there is a systematic approach to tobacco control, and there is a lack of capacity in healthcare professionals to address the issue. This brings me to the question to Dr. Mohanty, where I would like to ask him, what is the need in formal training for tobacco and related counseling, sir? How do you think this need can be addressed? Can continuing dental education be one way? Should tobacco cessation be a part of the dental curriculum, much more than just listing out the 5 A's?
Yeah, thank you so much. I think what you have touched upon is a very important aspect, because we're talking about building capacity, and the capacity is on the both the sides. What I mean by both the sides is, one is the current education system and the current education curriculum, and the other side is the already existing available professionals who are there. So when we talk about the curriculum, see, I am from the dental background, dental academia background. I can speak more about that and what changes have been done in the dental academia. As of now, when it comes to the curriculum part, both at the undergraduate level and the postgraduate level, there have been changes made since 2018 onwards, since the tobacco cessation clinic came into existence to the operational guidelines. We work closely with the council to integrate a complete structured program into the undergraduate curriculum. So, and that curriculum actually meant, it meant almost, and that also out of an experience. We have been running a cessation curriculum at our own institution for the last 6 years now. And my colleague and me, both of us have been instrumental in designing it and implementing it at an institutional level alone. But that curriculum is almost around 6 to 7 hours of training on different aspects of cessation, certain clinical observations, certain clinical exposures, some role plays, and at the same time, completing certain, what do you call, I would say, assessment of patients as a part of their learning. So all this comprehensively has been integrated over the last 6 years, and we have good evidence saying that, which says that this kind of intervention is successful. Yet to be published, but these same learnings from this particular intervention has been taken up and has been incorporated into the undergraduate curriculum, which is right now waiting for approval at the parliament. Still waiting approval from there. Whereas when you talk about the master's program, the MDS curriculum in dentistry, that already has components integrated in the public health dentistry specialty, where we have taken all this in a much more advanced way, as well as integrated tobacco control into the curriculum. So both these aspects have already been considered when it comes to the dental curriculum, I would say. Yes, we still have to implement it. That is, that we have already taken the first step. But I foresee that in times to come, we will be implementing it. If you look at the other healthcare professionals, again, I come back to that point. The medical fraternity also needs to look at this. The Board of Governors of the Medical Council of India, which is currently looking into the curriculum in medical sciences, also needs to incorporate. I'm sure some work would have been done already. And when it comes to that, that group, which is the professional group, there also, as of now, we all know that there are only a handful of courses available for cessation in our own country. And I think NICPR, NIMANS had, Madam will be able to tell more. We had one program from NIMANS, and Life First is obviously having a program. There's not much programs that are available for training. IDA conducts the TII, that is the Tobacco Intervention Initiative. It's a one-day program, very intensive, but one day is never sufficient for such training. So I think that we surely need more structured orientation towards cessation, because it's not a one-day affair. It's not something which you can just listen and learn. It is something which you have to go learn as a part of your, complete. The process is important in this, rather than just listening to lectures. And I think NIMHANS, I just completed a program on addiction management from NIMHANS, a very intensive program conducted by the Virtual Knowledge Network, the Digital Academy at NIMHANS. Very well structured program. Such programs are what is the need of the hour, actually. So I think these things put together, maybe we can, in times to come, we can see that we can have more implementation of these educational strategies.
Yes, sir. Thank you, Dr. Mohanty, for clarifying the academic interpretation of tobacco cessation services. Thank you so much. Rimanshu?
Yes. So yeah, that brings us to the end of the structured questions as such. So based on this conversation, I think like I'm just looking at the time, and time went quite fast. So maybe we can just take up a few questions. There are some questions already in the question and answer list. I've just roughly or quickly gone through them, and a couple of questions for Dr. Pratima Murthy. I'll start with that. It has generated a lot of interest, the Quitlines basically. So a quick question about like, has there been any formal evaluation of the Quitline program? And there is a question, like as a part of the same question, what we see over here is, what about the digital divide? So that is like, how do we address that? So if you could take these questions, then there are a couple more which you can come again later.
Sure. So the government has regular annual appraisals of the tobacco Quitlines. There's also some published work already from the VP Chest Institute. We're in the process of actually publishing the differences between the pre-COVID and the COVID. I think he's also asked about quit rates. I mentioned that, we had quit rates of about 19 to 20%, which have doubled during the COVID. And of course, the Vallabhbhai Patel Chest Institute in the initial things had actually higher quit rates than we did, but somewhere along the line, and I wanted to actually, take on Himanshu, the fact that workplaces are a fantastic place to do interventions. You mentioned the advantages of that, and we too, in our work with KSRTC, which is the largest, bus company, found for all addictions, actually their follow-up and outcome rates were phenomenally higher because of the nature of organizations. The second thing you mentioned about the digital divide, and I think there was a question about smokeless tobacco and versus smoking tobacco. At our center, it's roughly about 50%, 52% are smokeless tobacco users, and about 10 to 12% are combined users, and the rest of them are smokers. In the northern Quitlines, the smokeless tobacco use is much more, almost 2/3 are smokeless tobacco users. Now, the advantage is, if you look at mobile telephone penetration in India, it's huge. So, for example, you don't need a smartphone or anything like that to call the Quitline. You just need an ordinary phone. And practically, so many people now have a phone to call in. But there are, so it's a huge opportunity for people to be able to call in and, and get some help. The second thing, of course, is that when you look at gender, there you will probably start having, issues that, access to telephones, is there a gender inequity as far as that is concerned? So therefore, our women, we know that almost, I think, 18 to 20% are smokeless tobacco users among women. Now, do women have access to these things? I think those are important questions that we need to ask ourselves when we want to make it more, accessible to a lot of people.
Right. Yeah. So there is one question about areca nut, which I would ask Dr. Gupta. Sir, there is a question asking, are there any specific successful guidelines for quitting of cessation of or quitting or cessation of areca nut, or is it similar to tobacco?
There are no specific studies as such. I think, Himanshu, you would be in a position, I think, much better position to give evidence-based guidelines. But I think whatever we do about the smokeless tobacco, it should work in a similar way for areca nut also. What do you say, Himanshu?
Right, sir. So that is our experience. So it's almost similar to smokeless tobacco. The same principles are what we are applying. It is also an addictive substance, the areca nut itself,
Absolutely.
and it is also leading to similar side effects or health impact.
And
So
it is
we are
also
connecting it.
it is also
Yes, sir.
carcinogenic. That's most
Yeah.
important because of.
So we do stress on that during our interventions, especially with the children. We do stress on that, and even among adults, sometimes it is important to clarify that you cannot switch from a smokeless tobacco
Yeah,
to
to
areca
areca
nut.
nut.
Sometimes people feel that that is not tobacco anymore, and so they start using an areca nut product, which is what we advise against.
Absolutely.
Right. So thank you, sir. I think that is all that we have time for questions right now. So this was a really wonderful session. I'm sorry for a few questions which could not be taken up directly because of the lack of time. Thank you very much to all the panelists for their participation. Thank you to my co-moderator, Dr. Monique. It was really wonderful. So thank you all. Over to you, Dr. Abhiram.
Yes. Thank you very much, Dr. Monique and Dr. Himanshu. It was indeed an enriching and stimulating discussion. And after having discussed multiple approaches of cessation, I'm sure participants will also be excited to witness various models on tobacco cessation. Now we are moving towards the concluding part of today's discussion. I would now like to request Gauri Mandal and Deepak Patil to please take us through the conclusion of our discussion with vote of thanks. Thank you.
Thank you, Abhiram. Good evening, all. I am Deepak Patil.
And I am Gauri Mandal.
It's our privilege to have been asked to propose the vote of thanks. On behalf of Salambe Foundation, Narottam Saxena Foundation, and Life First, we would like to extend a very hearty vote of thanks to our esteemed panelists who not only grace us with their presence by taking out time of their busy schedule, but also share their expertise. I would like to thank Dr. Swasti Charan for leading the tobacco control activities at the national level. Your experience and thoughts will surely guide us to strengthen the implementation of tobacco cessation activities. Thank you.
A heartfelt thank you to Dr. P.C. Gupta for always guiding and inspiring us. Thank you for highlighting and emphasizing that smokeless tobacco and areca nut use in India needs more focus. You truly are a mentor for the entire tobacco control fraternity. Thank you, sir.
I would like to thank Dr. Pratima Murthy for her invaluable contribution in the field of tobacco cessation and sharing detailed information about the Quitline services and challenges associated while implementing the services for the tobacco users. Thank you.
Our sincere thanks to Dr. Upendra Bhojani for sharing thought-provoking insights about tobacco control policies, especially for adolescents. Truly, more efforts are needed to strengthen the tobacco cessation activities among adolescents and protect them. Thank you.
I would like to thank Dr. Vikrant Mohanty for clarifying the importance of our oral health professionals in tobacco cessation. Thank you.
Next, I would like to thank Ms. Manisha Khernar for her continuous efforts in creating tobacco-free environment at her workplace and for sharing Ambuja Cement Magdala unit a success story with us. Thank you.
A big thank you to Dr. Monique and Dr. Himanshu for steering the discussion in the right direction with your stimulating questions. Thank you for conducting an engaging and wonderful discussion. I would like to express my sincere gratitude to all the participants, including government authorities, NTCP members from various states, the NGO partners from different states, teachers, faculties, and students of dental colleges, dentists, and all the individuals for attending the webinars. Thank you all.
I extend my heartfelt gratitude to our seniors who have guided us throughout. A big thank you to the dedicated team of Salam Mumbai Foundation, Narottam Saxena Foundation, and Life First, with a special mention of the IT and the communication team members for their support. Thank you to one and all for making this event successful with your contribution. And with this, we officially end this webinar. Thank you. Thank you, one and all.
Thank you all. Thank you.
Thank you. Thank you, everybody.
Thank you, sir.
Thank you very much.
Thank you,
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, Dr. Mohan.
Thank you, Vikrant, sir,
Thank you.
Thank you, everyone.
Thank you.
for bearing with me.
Thank you. Thank you.